Good morning to everybody. We are going to start this webinar meeting of this morning that is focused on hemoperfusion. As you know, hemodialysis of our chronic patient has been based for several years from two cardinal points that are diffusion or convection. Diffusion are being used in chronic hemodialysis patient, either in the low or in the high flux methodology. And afterwards, we are going to introduce hemofiltration and hemodiafiltration, where convection is added to diffusion. But every one of us that is working hardly with this type of patient considers that probably we are not doing enough. And so we are now this morning going to explore the third dimension of this situation, that is hemoperfusion. So I would like to thank Jaffron that has organized this meeting this morning, and my colleagues that are going to give us some very interesting presentation in regard to this. I have to introduce the speakers. So the first speaker is myself. So I am going to introduce myself. It's very easy for me. I have been studying in Pisa University since several years, and now I am going to work in Versilia, that is very nearly to Pisa. My field of interest is hemodialysis, and principally is a state of chronic inflammatory states of our patients. So I am going to give you a brief exposition regarding protein-binding uremic toxins and describing a short and brief pilot study cartridge in our patient. So if I can have my first slide, I am going to give you my talk. Is possible to have the first slide, please? Okay, can you see the slide?
We don't see the slide.
Can you see the slide? Okay,
yes.
So I am going. Okay.
Oh, yes.
Alima, good morning. Good morning. Good morning. So, as you know, we have three types of uremic toxins: small water soluble, the very well-known urea and creatinine, the middle molecules that are represented now by beta-2 microglobulin, and protein-bound solutes, the more modern type of uremic toxins can be involved in uremic toxicity. So indoxyl sulfate and picozoles are the most well studied of these toxins. As you can really see in this slide, uremic toxins, protein-bound uremic toxins, are inversely related to renal functions that are going to increase for the latest stage of renal function disease, KCD stage 5 and HD, the higher situation of both pocresol and indic sulfate. And this type of toxins are 44 and 22-fold higher in CKD patients in respect of healthy volunteers. Of course, residual renal function is the main effect in removing protein-bound solvents. So the reducing of uremic of our kidney function, of urine output, is going to make the greatest increase of this type of toxins. Of course, renal transplantation is the best ways to remove this type of toxin, and so you can see data after 1 and 12 months of transplantation in patient with a well-working kidney transplant. Why these P-boots, protein-bounding uremic toxins, are so dangerous? They are so dangerous mainly for two types of questions. The first one, because they are associated with a shorter renal survival. Here you can see two populations, the population with higher indoxyl sulfate and peak results levels showed a remarkable, significantly decrease of renal function after a time follow-up. But not only renal function is involved, mainly they are also associated to mortality in this patient. So this is the first paper that demonstrated this fact, the first time that free serum levels of protein-bound uremic solute are associated with mortality in patients treated with hemodialysis. And there are a large amount of paper mechanism of uremic toxin toxicity, and is going to induce renal fibrosis and so to decrease renal function. But not only, they are going to increase systemic inflammation, oxidative stress, endothelial dysfunction, and going to cause cardiovascular disease that is so frequent in our patient. Furthermore, we are going to more molecular mechanism. These are the NFKB, the key message, the key mediator of the production of a lot of TGF-beta, fibronectin, and several other mediators that is going to give us renal tubulointerstitial fibrosis and glomerulosclerosis. What are the therapeutic strategies that we can use in reducing uremic toxin? Reduce gut synthesis, gastrointestinal sequestration, reduce proximal tubular retention, but in the few minutes that are remaining me, I'm going to convince you that renal replacement therapies are going to do something good in this type of patient. Of course, standard hemodialysis is not good enough because only 30% of these toxins are removed. If you are going to extend dialysis time even to 8 hours, we have an increase in reduction of this type of molecules. Of course, nocturnal hemodialysis is going a little bit better because is lasting much more time, so 8 hours at least. These are data in mid and post session. And also, of course, if you are going to increase dialysis flows and dialysis surface, we can have an improvement in this depuration. But probably this is not enough. So we have tried with convective strategies, and the addition to convective to diffusion is going to increase the reduction of this type of molecules, either through this CT17. We have tried to measure indoxyl sulfate and peak results levels after 6 months in patients that have been treated with a high volume hemodiafiltration, with a high flux of hemodiafiltration over 23 liters per session. As you can see, after 6 times, we observed a reduction in indoxyl sulfate level in this patient. But the topic of this morning is adsorption, that is a chemical attachment of a specific element to surface with a molecular structure prepared to be complementary. So this is a cartridge that is going to absorb blood and plasma, in our case blood, and several types of methodics have been previously introduced. Hemoperfusion this is another slide. This is a cartoon where you can see the hydrophobic interactions that occurs with the resin and some molecules. So also the antibody can be attached over the resins. Now we are going to speak in this morning by this HA130 hemoperfusion. That's a type of cartridge that has been introduced by Jaffron, and these are the main characteristic of this cartridge. And we are going to listen to your presentation is the next time that are going to better explain us what's going on. These are the general characteristic of this cartridge. Several small studies have been produced, mainly in China, where this cartridge is coming from. So you can see PCR, beta-2 microglobulins, are going to decrease after. You can look at this data, not at the first time, but we need at least a longer period of time to obtain some good results. This is a very recent paper, 90 patients in 3 groups, alone, perfusion, and perfusion twice. And now we have performed this very small, very pilot, very observational, non-randomized studies that we try to investigate the effect of the cartridge using perfusion in patients suffering from severe itching. 7 patients and 10 control, 8 weeks was the time. Prurite score was used by the VAS, and also we have measured beta-2 microglobulin, KT overview, and protein-bound uremic toxins levels at the same times. This is a dialysis technique. We have used the cartridge for 4 hours, and this is a point that can be discussed later because there is no univocous strategy in our dialysis unit, I believe. And we have used the cartridge once a week. For the first week, we have used twice, and afterwards once a week in the following 7 weeks. And also this is a topic can be discussed later. This is diuretic efficiency. This is KT over V and beta-2 microglobulin levels that are slightly reduced in cartridge patient and slightly increased in patient receiving hemodialysis. But this is very interesting and unexpected. We observe a significant reduction is in P-boots plasma levels in patients receiving the cartridge after 6 months, after 8 weeks of treatment. So, as you know, several papers have been produced. This is a little summary of this. And my conclusion is very obvious, of course. Time of KT overview in our patient program is going to be finished. We need to preserve kidney function because kidney function is very important in removing uremic toxins, so incremental dialysis can be of interest. And absorption plus HD, standard hemodialysis or hemodiafiltration, high volume, or what you prefer, can be a good therapeutic option in our patient. So I have finished, and I am going to introduce Alma, that will be the next speaker. Is working in, she's from Bosnia and Herzegovina, is working in the University of Sarajevo, and they are the group of Amela Berijacis. They are very interested in hemoperfusion, and they have still 17 patients that have been chronically treated, and they have a very long of several years experience in this technique. So we are very interested in listen at your talk. Please, Alma, thank you.
Thank you very much, Professor Vincenzo, for your introduction. I'm Alma Mkadalic-Turkovic, and I'm working on the University Clinical Center of Sarajevo. I'm a nephrology resident, and I did this topic together with my chief, Dr. Amela Bečeragić. We have a total number of 17 patients, and we did a follow-up just 1 year, not several years, but just 1 year. So I'm going to share my screen, and I'm going to tell you something about my presentation. So at the beginning, I introduced myself, also as I did my chief, and our topic for today's webinar was middle uremic toxin clearance by combining hemoperfusion with hemodialysis. First, I'm going to give a brief introduction about this method, but it's not going to take long, so that I and Professor will not repeat ourselves. As we all know, one of the major functions of the kidney is to excrete and eliminate waste products and toxins, which are mostly generated from a variety of metabolic processes. As we all know, the retention of these uremic toxins cause the various clinical symptoms of uremia, which is present in advanced chronic kidney disease. Some of our studies have shown that the occurrence of this mid and long-term uremic complication is related exactly to that low clearance rate. One of these complications are irreversible and cannot be alleviated even after renal transplantation, which poses a challenge to the long-term survival of patients on dialysis. When it comes to a matter of time, before the 80s, there was just low flux dialysis. Afterwards, there were high flux, and then there are a newest method like it is adsorption. Adsorption is considered a complementary mechanism for solute removal, which relies on direct binding of solids to membranes or sorbent materials. An important characteristic of these sorbent materials is that they are minimizing unwanted molecule loss, which is frequently encountered using other extracorporeal blood purification techniques. Some of our studies shows that they are reducing the leptin concentration in patients which are receiving hemoperfusion. For example, I gave you this slide because this slide shows an ideal combination, not just for removing small uremic toxin and part middle uremic toxin by the method of hemodialysis and hemodial filtration. They are also, together with hemoperfusion, excreting middle uremic toxins and protein-bound uremic toxins. There are different indications for patients who will receive hemoperfusion, and therefore there are 3 types of treatment solution. As you can see on these slides, there are 3 types. Those are intensive treatment solution, maintenance treatment solution, and individualized treatment solution. So in the next few slides, I'm going to give you brief conclusions from different studies about these hemoperfusion methods. Some studies say that they are improving the overall survival and improvement of sleep disorders. Other ones said that they are improvement not just in clinical parameters, as well as they are in pruritus, hypercalcemia, hyperphosphatemia, and parathyroid hormone. They are also associated with the reduction of pruritus score and parathyroid hormone, and increase in nocturnal melatonin concentration, secretion, improvement sleep disorder, and mostly important in the improvement in the overall survival rate. As you can see here on this slide, there are listed some of the benefits of the method of hemoperfusion. But now I'm going to switch, after this brief introduction, I'm going to switch to our experience. We started this method last year in June 2012. By that point of the year, we only had 1 patient. By the end of the 2019, we had a total of 7 patients working and receiving hemodiafiltration and hemoperfusion. By the end of this year, or by the end of the last month, we had a total of 70 patients. Because the lack of these HA cartridges that we had, in the beginning we had just 7 patients, so we decided to do a brief follow-up of those 7 patients according to their clinical, sociodemographical, and laboratory values, also on their sleep quality. Afterwards, as the number of the patients that received this method grow, we decided also to do an evaluation of the all 70 patients, which I'm going to show you later on this slide. So here are some some abbreviation of the synonyms that I'm going to use later on in my presentation. On this slide, you can see some clinical characteristic of our first group of study that we did. You can see here that they are mostly male with an average age in years, which is 37, and an HD duration of 150 months. The indication for including and receiving the patient of this method was mostly they're younger and middle-aged. Then they were longer on the treatment of hemodialysis. They were awaiting for transplantation because they were on the federal list of transplantation and had a lot of symptoms of long-term dialysis, which were mostly pruritus, renal osteodystrophy, sleep disorders, and refractory hypertension. When we are talking about this 7 patient, we can see that disease caused by this renal failure was mostly chronic glomerulonephritis, and most of them were also unknown. When we are talking about laboratory data that we took before and after applying the hemoperfusion method, we can say that we had an improvement in laboratory data, especially in lower CRP and in phosphorus. As I said it earlier before, because of the lack of these HA cartridges, we had only at the beginning 7 patients who some of them received this treatment once in a week. Some of them received it bi-weekly. Some of them had 7, some of them had 6 treatment. We didn't have a maintained treatment just because of the lack of these cartridges. The other 10 patients that were included in the study had a maintenance treatment, which was once in a week, in 2 weeks in a row. After that, they received it bi-weekly, and after that, once in a month as a maintenance dose. So here are also listed some sociodemographic characteristics and parameters which are related to the SQ of group of patients. So what is an SQ? We did an analysis of sleeping disorders of our patients. SQ means that there is a questionnaire who is introducing our patient as bad or good sleepers. Most of complications from long-term dialysis, which is related to this score, are pruritus and breathing problem. Our psychologist, Mrs. Badema Cengic, did a questionnaire before and after receiving hemoperfusion. Before receiving hemoperfusion, our patients were listed as bad sleepers, as you can see here at this global PCQI scores, which means that higher level of this score means that they were bad sleepers. After introducing this hemoperfusion method, after a follow-up period, we did the same score, and we have noticed that these patients turned out to be better sleepers. So this was one of the benefits of our hemoperfusion treatment. As the time passes by and as we had more cartridges, we were able to include more patients who received this hemoperfusion. So as I said it earlier before, until the end of the last month, we had a total of 70 patients. So what we have done, we took those 70 patients and compared their social demographic, clinical, and laboratory characteristic before and after applying hemoperfusion, and we also compared them to the other 2 control groups, and we did follow up them for a period of time. When we did the descriptive statistic, you can see that this descriptive statistic of all patients that were included in this study are listed here in this table. Also, you can see the descriptive study of our patient who received hemoperfusion in this table, which are the duration of hemodialysis, the values of hemoglobin, their EPO doses, the values of ferrum, of TIBC, of albumin, of phosphorus, parathyroid hormone, and calcium. Also, here are listed some of the graphicons that show the gender of patients, which we can see that they were mostly male. We can see also the BMI characteristic of those patients, and we can see the vascular access in the patients that we included in the study. So, as I said it earlier before, we analyzed the clinical, laboratory, and socio-demographic data before introducing the HP method to them. And when we are looking at the difference between our experimental and control group, we can say that at the starting point of our measurements, there were no statistical significance differences between research groups when it comes to laboratory data. But when it comes to the HD duration and when it comes to the age of patients, we can see that the patients who received hemoperfusion were longer on hemodialysis than the other two control groups, and also they were younger age than the other two control groups. After the follow-up period, after receiving the hemoperfusion treatment, we did the same comparison when it comes to those clinical, laboratory, and socio-demographic characteristics. There were no differences between those groups who were observed in gender, BMI, vascular approach, HD duration, parathyroid hormone, and calcium. But significant differences were noticed between patient age, HD length, TIBC, albumin, and phosphorus. Phosphorus level in our group who received hemoperfusion was significantly lower than they were in the other two control groups. Also, significant higher levels of TIBC and albumin were noticed in the experimental group. Not that just we did a comparison of the experimental and control group, we also did a comparison between the laboratory, clinical, and socio-demographic data in this group of patients who received hemoperfusion. So we analyzed them before and after introducing this therapy. And we can say that the phosphorus level were significantly lower after the follow-up period compared to the baseline. Also, the values of the parathyroid hormone were significantly lower after the follow-up period compared to the baseline, and we notice a tendency to increasing the levels of TIBC. So, when I showed you our result, we can conclude that after receiving this hemoperfusion treatment, our patient had an improvement in our laboratory data. The improvement in the laboratory data gives an improvement in their clinical characteristic, and therefore it gives them an improvement in their quality of life. After this hemoperfusion treatment, we talked to our patient, and all of our patients reported that they were subjectively feeling more better and that they had a better clinical state than they had earlier before. So we accomplished our goal. Not that we just had a blood purification technique, we improved the quality of life of our patients by shifting and trying to put them back in the society as a normal person. As you can see, the conclusions also of other studies says the same, and they are saying that this method was superior to HD in regular eliminating middle and large molecule uremic toxin, and also these findings suggest a potential role for this method in the treatment to improve the quality of life and survival rate of our maintained hemodialysis patients. Thank you so much for your attention.
Thank you very much, Alma, for your very nice presentation, very clear, good. So now we are going to listen at a recorded presentation that is given from Dr. Pasco Stiliani from Greece that have been involved in a different meeting, so she apologized, but this cannot be with us. So I I'm going to ask Jaffron Gears, very active, so that I want to say thanks for the technical assistance to give the presentation of Dr. Pasco that is recorded, is a 9 minutes presentation, so we can go through.
Good day. I am Dr. Styliani Pascu. I'm a nephrologist at the nephrology department of Papa-Nikolaou General Hospital of Thessaloniki, and I will speak to you about our experience with combined hemoperfusion with hemodialysis for treating long-term dialysis complications. Dialysis population is growing worldwide, and long-term hemodialysis related complications are the following: cardiovascular disease with left ventricular hypertrophy, refractory skin itching, renal osteodystrophy, resistant hypertension, neurologic disorders such as restless leg syndrome, peripheral neuropathy, encephalopathy, and sleep disorders, malnutrition, deterioration of residual renal function, and so on, resulting in a decline of patients' quality of life. So the occurrence of these complications is shown to be the decreased clearance of uremic toxins, middle and large molecular weight. This familiar to all table shows the classification of known uremic toxins. On the left side, there are small water-soluble solutes, such as urea and creatinine, that are below 500 Daltons and are easily removed by conventional hemodialysis. On the right side, there are the middle molecules. Their enhanced removal is succeeded with high flux membranes and convective strategies. And in the middle, there are the protein-bound solutes, such as picresol, indoxyl sulfate, and the so-called AGEs, that have been demonstrated to be an independent predictor of the severity and poor prognosis of cardiovascular disease. Adsorptive therapies may play an interesting role in their effective removal in the future. So we decided to initiate this hybrid combined method of hemoperfusion with hemodialysis in 4 of our unit patients. Here are the demographic and clinical characteristics of the patients. Mean age is 59 years old, and mean vintage, long stay in hemodialysis, is above 10 years. All 4 patients were male, over 50s. They were stable, with no active infection or hepatic disease. They were on online hemodiafiltration thrice weekly, with high vintage and secondary hyperparathyroidism in need of high amount of medication. However, the main reason we chose these 4 patients was uremic pruritus. So our first case is a male, 61 years old, with a history of GPA, on maintenance hemodialysis for the last 15 years, and his main complaint was moderate to severe itching. Here is his hemodialysis data sheet. As you can see, he's on online hemodiafiltration pre-dilution 4 hours thrice weekly. Our second case is a 69-year-old male with severe secondary hyperparathyroidism in need of maximum doses of ethyl-calcetide and paricalcitol. Here is his hemodialysis data sheet. Our third case is a 54 years old male with polycystic kidney disease and a history of idiopathic thrombocytosis. He has poor compliance about his dietetic advice on phosphorus intake and medication dosage, as you see with his medication for hyperphosphatemia and hyperparathyroidism. Here is his hemodialysis data sheet. I remind you that the patient has a history of idiopathic thrombocytosis, so as a dialysate fluid, we chose to use citrate as an adjunctive way of anticoagulation. And I have to note that this patient is above 100 kilos weight and above 195 centimeters high, so he has a large body surface area. Finally, our fourth case is a 52-year-old male, former kidney transplant with IgA nephropathy on hemodialysis for 13 years in total. He has resistant hypertension with high doses of antihypertensive medication. Here is his hemodialysis data sheet. So all 4 patients received this hybrid combined artificial kidney for therapy once per week for the first month and then once per month from December 2019 up till now. The hemoperfusion apparatus was connected in parallel and equipped before the dialyzer. We used 7,000 international units of unfractionated heparin in the hemoperfusion apparatus according to the manufacturer. Adsorptive therapy started for the first 2 hours on each patient with a blood flow of 250 milliliter per minute. And past its saturation time, the patients received online hemodiafiltration for the next 2.5 hours with a blood flow of 350 milliliter per minute. We used unfractionated heparin for the anticoagulation of the circuit according to ACT values. So, after 6 months of observation, all 4 patients claimed the sense of skin itching improved from moderate to mild or no itching. For this short period of observation, dialysis adequacy was not adversely affected. Moreover, it showed an improvement trend. Serum albumin, a nutritional and inflammation negative laboratory marker, was above normal values for all 4 patients. This also shows that the combined method of hemoperfusion with hemodiafiltration had no harmful effect on plasma protein of the patients. As for PTH values, we had mixed results. In 2 of the patients, PTH values remained stable or even decreased. And for the other 2 patients, parathermal values peaked above 1,000 picograms per milliliter. One possible explanation for our 3rd patient was the reduction in paricalcitol dosage due to hyperphosphatemia. I remind you that this patient has poor compliance on his dietetic advice and medication dosage for phosphorus intake. And patient number 2 is investigated for tertiary hyperparathyroidism. Calcium and phosphorus values did not change for each patient during the course of the period of observation. As for their liver function and complete blood count, values remain between normal range. So in conclusion, the experience from the use of combined hemoperfusion and hemodiafiltration treatment in our center was so far rather positive. All patients claimed the skin itching improved. There were no adverse effects such as hemodynamic instability, hemorrhagic diathesis, allergies, or any other manifestations of bioincompatibility. Hemodialysis adequacy, plasma protein, liver function, and blood cell count were not negatively affected. But I have to remind you the short period of observation that prevents us from extracting any other safer conclusion. And the fact that this combined novel treatment strategy aims to achieve a long-term improvement on patient survival and quality of life. Thank you.
So we are moving to the last presentation of this first session that will be given by Sandra Derkelica. The title is Clinical Practice of Hemoperfusion for Dialysis Patients. Sandra is working in the dialysis center of Riga in Latvia. Please, Sandra.
Good morning to everyone, and thank you for the invitation and for the opportunity to share our clinical practice of hemoperfusion for dialysis patients in our dialysis center in Latvia that we have observed together with my chief, Dr. Aldis Pudas. Latvia is a country in the Baltic region with a population of 1.9 million. On 2018, we had 1,020 patients registered on renal replacement therapy, 1/3 on hemodialysis. The highest mortality in hemodialysis group, and in our dialysis center, we have in average 50 patients. The first hemoperfusion we performed on August 2018, and the patient was 47-year-old woman with primary arterial hypertension and hypertensive nephropathy. She received maintenance intermittent hemodialysis for 8 years. She had high uremic toxin concentration, severe itching complaints, and severe hypertension. So we started hemoperfusion, HA-130 added to hemodialysis for 2 hours each hemoperfusion session every 2 weeks. No improving of complaints during the first year. And after 16 months, hemoperfusion treatment was intensified to every week. Pruritus disappeared after 3 months. For assessment of pruritus, we used visual analog scale with marks from 0 to 10. To our patient, before starting hemoperfusion, rating in visual analog scale was 8, but after 3 months on hemoperfusion every week, this rating in scale was 0. We performed routine laboratory tests, and there was decrease in urea concentration, increase in KTV 1 year after hemoperfusion was started. There were no significant change in creatinine and phosphorus concentration, and PTH decrease was after 6 months of hemoperfusion added to hemodialysis every week. What else we noticed is that after 18 months on hemperfusion, we required 2 times lower EPO doses. So we performed a small survey on itching and routine hemodialysis laboratory tests, and what we found that itching is a common problem in maintenance hemodialysis patients. And we found that there was no significant difference in phosphorus and urea concentration for patients with and without pruritus. So we conclude that probably we should include in a routine use other laboratory tests having a better correlation with itching. The next patient is 28-year-old man with end-stage kidney disease after acute kidney injury. He had severe peripheral neuropathy, difficulties walking, and we started hemoperfusion 6 months after he started hemodialysis. So hemoperfusion was performed 2 times per month. And during the first year, we noticed that there was increase in KTV and also significantly improved walking ability. Another patient, 63 years old man with obstructive nephropathy and maintenance intermittent hemodialysis for 2 years. He had low KTV and high calcium phosphate product, and he received hemoperfusion added to hemodialysis 2 times per month. PTH decreased after 3 months. KTV increase we noticed after 1 year on hemoperfusion. So on June 2020, in routine laboratory tests, we noticed that there was significant decrease in urea and phosphorus compared to 2 months ago. And there was the question, is this the effect of renal replacement therapy? But we knew that the patient had dietary restrictions due to exacerbation of pancreatitis. So some routine laboratory tests we use for assessment hemodialyzed patients' treatment efficiency depend also on patients' compliance for the treatment. To summarizing our data of 5 patients who received hemoperfusion, we see that there was decrease in urea and PTH concentration 6 months after starting hemoperfusion. KTV increase we noticed for 3 patients after 6 months, and after 12 months for the rest 2 patients. There was no decrease in albumin and total protein level, and no significant change in creatinine and phosphorus concentration. We have started HA-130 hemoperfusion for several other patients with complaints of pruritus, severe hypertension, high calcium phosphate product, high PTH, and insufficient KTV. And analyzing KTV in 1 hemoperfusion and hemodialysis session, which for now, due to no recommendations and instructions from the manufacturer, we perform this hemoperfusion during all hemodialysis session during 3.5 till 4 hours. So we get that for 4 patients there was increase in KTV, but no increase for another 4 patients. So those data should be observed over a longer period of time. And for future, we are interested in the effect of hemoperfusion treatment on complaints for sleep disorders and weakness after hemodialysis. To comment practical aspects, so we used in aspirins liquid 5% glucose for all patients, and also saline with lower heparin dose, as it is mentioned in instruction. Our experience with hemoperfusion was for 4 hours added to dialysis with extra bolus heparin to usual heparin dosage, and after 2 hours we returned blood and disconnect the hemoperfusion cartridge. But for now we have extended this time for hemoperfusion during all dialysis session for 4 hours, and also we have tried this hemoperfusion with usual heparin dosage and there haven't been complications till now without clotting or bleeding, and also didn't notice any changes in coagulation tests or platelet count. Blood flow rate initially was 200 milliliter per minute. For now, we have increased it till 300 and even more due to routine patients' blood flow rate during hemodialysis. So, in conclusions, I would like to mention that HA-130 hemoperfusion has been proven to be effective in pruritus relief and reduction of peripheral neuropathy in end-stage kidney disease patients on maintenance intermittent hemodialysis. Patients' quality of life was improved. HA-130 hemoperfusion added to maintenance hemodialysis treatment for more than 6 months improved uremic toxins, urea and PTH removing, and increased KTV. Patient's life expectancy may be extended, and there may be other uremic toxins removed and symptoms of end-stage kidney disease and hemodialysis complications relieved, with HA-130 adding to hemodialysis. Of course, this would require additional research and observations. So thank you for the attention, and this is our capital, Riga. Thank you.
Very nice, Riga, very nice your talk. You have been very clear, and I would like to thank all the speakers in remaining in the time, so we have enough time to have a discussion. Before starting discussion, I would like to introduce two new friends that have been joining us. Professor Alima Rezic, that is the president of the Society of Nephrology and Dialysis and Transplantation in Bosnia and Herzegovina. So I would like to congratulate with this great honor, and she's going to join us in our discussion, and also is joining us Dr. Dimitris Petras, that is coming from Athens. He's a director of the nephrology department in General Hospital Hippocration, and so they're going to have discussion with us. So I have prepared a few questions. I am trying to give you the same question and waiting for your answer. So we can make a round of the table. We have no table, but we eagerly our table. And so I am going to start with Alma. And the first question is, what is the type of patient that you believe is good to be treated with this new technique? Young patient, old patient, inflamed patient? What's your opinion? You have treated, I remember, very young patients, no? So tell us something. And after, I would like to hear from Sandra to Professor Alima and Dr. Dimitris just for the same question. Brief answer, please, so we have time to give you more questions.
Thank you, Professor Vincenzo, for asking me those questions. First, I have to say that we have chosen patients to be on the treatment of hemoperfusion were patients who were younger life age and middle life age. Also, we had patients who had very high values of phosphorus, very high values of parathyroid hormone, who had their clinical aspects of these clinical values like pruritus. Also, we had patients with a refractory hypertension, and all the patients were awaiting transplantation on the federal list for transplantation, so that we can improve their overall and medical state with this hemoperfusion technique.
Okay, thanks. Sandra?
I would say that we could choose patients with severe uremic complaints for itching, also for high PTH and insufficient KTV. Thank you.
Okay, Professor Alima.
Yeah, I think that this presentation for our doctors presents the same thing, that the main indication is that we can always fight in dialysis with our patient about renal osteodystrophy, itching, and so. So I think that that is a problem by nephrologists, especially in newly-developed countries, in Bosnia and Herzegovina, and where we have no transplantation. And I think that a presentation for Dr. Turkovic and so a great number of patients is really one key point for the better quality of life for the patients. So I think that is the main indication. The main indication is that clinical problems with renal osteodystrophy, because itching is not so present so much as 10 years ago, for example, yeah, when we started. Now we solve itching, we solve hepatitis C, but we didn't solve renal osteodystrophy yet, yeah. So I think that hemoperfusion can help us that.
Okay, so mainly osteodystrophy. Dimitris, please, good morning.
Good morning, thank you for the invitation. We start with patients that complained about itching, and then we spread in patients with high PTH. We didn't have patients with sleep disorders or with uncontrolled hypertension. One other thing is that we try to have patients that did not so much time in dialysis. Usually people that they are more than 10 years in dialysis, I don't think they are going to have much improvement. So we start first people that they are less than 10 years, so to improve and not to have complications that cannot be treated. So of course we have some patients waiting for kidney transplant. I think it's very important for them to have a very good dialysis with the best we have.
Okay,
thank you.
Thanks for this topic of the time of starting, because has been also asked from the web. One of our listening has asked us, why don't we start hemoperfusion just with the starting of hemodialysis treatment in order to avoid further complications? And this is a point that you have well noticed. We can go to the second question. Now I am going to start from Dimitris and go to Alina and go back in this way. So the second point, and is a very important one, is what's the schedule that you suggest to our colleagues to start hemoperfusion? Because looking at the literature, to the papers that have been presented, and also to your experience that we have listening with much attention in these minutes, there is not an univocous way of interpreting this methodology. Someone is going to do it once a week, once every 2 weeks, once a month. Starting is different from the maintaining ones. What's your impression? What's the right schedule of this technique? And also questions have been arised regarding duration of therapy. 2 hours or 4 hours, like the more modern indication. Please, Dimitris, and after Alina, Sandra, and Alma, in this way.
Okay, so in our patients, now we have 15 patients. We start with 1 per week for 1 month, then once every month, and Now we are about, all the patients, they have about 6 months, we haven't stopped. So this is the frequency that we use. You're true that it's not so in the literature, there are not indications. So I believe that everyone is doing what the experience is saying. Duration, usually 2.5 hours, and then we continue with dialysis. We don't have any problems with anticoagulant use. We use the same anticoagulant that we use in all dialysis patients. We use low weight heparin, low molecular weight heparin, so we don't have any problems with coagulation. And we didn't observe during this period for this patient any adverse events. Everything was the same.
Okay. The last question that I forgotten. Blood flow. 200, 300, 350.
Sorry. Usually when we're doing the 2 hours and a half, we use 250, and then we continue with 330, 350 ml per minute.
Okay. Thanks very much, Dimitri. You have been very clear.
Thank you.
Alina, please.
For intensive treatment, recommendation is for the patients with a longer dialysis years and with complications such as renal osteodystrophy, poor nutrition, skin itching, peripheral neuropathy. Recommendation is 4 times monthly, change to maintenance treatment after conditions have been controlled. A recommendation for the patient with shorter dialysis year for preventive treatment of patients without dialysis complication and after intensive treatment, recommendation is 1 to 2 times per month. Individualized treatment is for refractory hypertension, for example, 1 time weekly, lasting for 8 weeks. Refractory skin itching, 3 times weekly, lasting for 2 weeks, and CKD, MBD, renal anemia malnutrition is 1 time weekly, lasting for 12 weeks. That is some recommendation. And in Sarajevo, Alma told that the best what we use and has the best experience which type of treatment started.
Okay, thanks very much, very clear. Sandra.
In our practice with hemoperfusion 2 times a month, we didn't get improve for pruritus, but for other patients with insufficient KTV, high PTH, there was increase with 2 times a month hemoperfusion treatment during 6 months. So for now we have intensified, and we are hoping that those effects will be better. About duration, actually there was effect even on 2-hour hemoperfusion in a longer period of time during 6 months. So I think there should be more observations and compares between different groups to make some other conclusion for that. What about anticoagulant use? As I mentioned in my presentation, that our first experience was with extra 2,500 units of heparin, but now we use routine, patient's routine anticoagulation without any clotting or bleeding. And also we didn't notice any other adverse effects. And about blood flow rate, so for now we use the patient routine blood flow rate during hemoperfusion, and it's from 270 till 350 without any complications. Thank you.
Okay, thank you. Thank you. Very nice. Alma, finally, last but not the least.
So when it comes to our experience that we shared in our unit, the treatment frequency, as I said it earlier before, for the first 7 patients, because of the lack of those HA cartridges, were mostly individualized. So we didn't have maintained treatment, we did individualized treatment for those patients, but the other 10 patients that we included in our study received hemoperfusion treatment once in a week, 2 weeks in a row. Afterwards, they received it bi-weekly, and then they received it once in a month as a maintained dose, and they are going to receive it still more because we are continuously monitoring them for this a longer period of time. When it comes to the duration, we did a treatment of 4 hours together with hemodiafiltration. We used the same anticoagulant dose that we were using when it comes to regular hemodialysis treatment. About this adverse effect, we had no adverse effect when it comes to some kind of allergic reaction, but we did had two times we had a clotting in the system by 2 patients. On the first treatment that we had by our patient, after 2.5 hours of the treatment, we had a clotting in the system, but I think it is due to the changing of the vascular access by the patient, and I have to say that didn't repeat it anymore, and this patient received around 7 or 8 hemoperfusion treatments.
Okay, thank you very much. I've been very interested in listening to your impression, and so I believe that probably we need some clinical study aimed to really better investigate the timely of these techniques that is really promising, but as listening your talks, there is a little bit now differences in our schedule, so we probably need some clinical study more precise. The last question: how do you evaluate the efficacy of your treatment? Do you use lab parameters, clinical patterns, life quality, or what do you prefer to be investigated? Alma.
Me first this time. We evaluate the efficacy of hemoperfusion treatment on the way that we listed the clinical and laboratory data before and afterwards. As I said it earlier before, we took the laboratory data of parathyroid hormone, phosphorus, calcium, and so on, and monitoring them before and after this hemoperfusion treatment, and we concluded that there was an improvement in this laboratory data. Also, we did some studies about the epidose, which we didn't had statistically significant results, but I do believe it is because of the small sample and the shorter period of follow-up, but in the future I think it will probably give us some results. Also, as if you were listening to my presentation, I said that we also evaluate this efficacy on the way that we questioned about the sleep quality of our patient, and we have proved that the sleep quality was much better after introducing this hemoperfusion treatment than before. So when we are improving the laboratory data, we do improve the clinical aspect of the patient, and therefore we improve their subjective feeling, and I think that it's an overall improvement of their life quality.
Okay, Sandra?
In our practice, in my presentation, there was a retrospective summary for several patients on hemoperfusion. So we based our hemoperfusion efficiency on patients' clinical symptoms like pruritus and also on laboratory tests, PTH change, also KTV change. Thank you.
Okay. Alima, please.
I think the most important is that the quality of life is better, especially we know that demographic characteristic of our patients in Bosnia and Herzegovina, we have 40% of patients over the 75 years old. So Alma presents that the quality of life is sleeping disorders is better, and I think that is really very important, and I believe in that, and also that clinical symptoms. Uremic toxins, all uremic toxins we could not measure, but I think important is that quality of life and clinical symptoms and subjectives of the patients, what happened in Sarajevo.
Okay, thanks. Dimitri.
Okay, we evaluate from uremic toxins PTH and the levels of beta-2 microglobulin. Then it's important for us the clinical symptoms and the quality of life, and we try to evaluate them with questionnaires, and we have seen some improvement in this. This is the measures until now. We are planning to have some more about uremic toxins, but we need to have uremic toxins were not like urea, we're not more special. So we are speaking with the laboratory to have some middle molecular weight molecules to evaluate.
Okay, very interesting. I will hear your data in the future, I hope. Okay, so we conclude this part of the discussion. We are perfectly in time. I would like to thank all the panel for this discussion. And finally, I call Professor Alima Rezic, that is going to give us a speech regarding the evaluation of the effect of the cartridge HA130 hemoperfusion sorbent on maintaining hemodialysis patient. She is going to share the clinical study of HA130. Please, Alima.
Thank you. Good morning to everybody and all participants one more. And I want to thank Jeff Frond for organizing that webinar, and also Professor Van Holder, who support us to make design this study. As you know, as Alma told, we in Clinical Center Sarajevo, we started that 1.5 years ago, and we wanted to make one evidence-based approach that can help to identify the best therapeutic option to be offered to maintenance dialysis patient in Federation of Bosnia and Herzegovina for reimbursement by appropriation health insurance funds and inclusion of hemoperfusion devices in the funding list. I want to point that because in Bosnia and Herzegovina, cadaveric transplantation is at the low level, and we have not enough transplantation. So all demographic characteristic and old age of patients need that we improve the quality of life. And I think because of that, we would like to make one study. Identification of clear inclusion criteria for the application of hemoperfusion in dialysis patient and definition of the optimal application treatment should help to identify the proportion of chronic dialysis patient, potential beneficiaries, and hemoabsorption to determine the number of procedures per month, and to extend of additional investments and fund allocation needed. I would like to say that by data of our renal registry in the in 2019, we have about 2,700 patients on chronic hemodialysis. Hemodialysis and diafiltration combined with hemoperfusion and which different devices H130 represents the optimal option in end-stage kidney disease for uremic toxin removal and patient quality of life. Collect relevant data and monitor effects of application of hemoperfusion in 10 maintenance dialysis patients in clinical center Sarajevo for 6 months. And to compare, we want to compare predefined parameters with 10 maintenance dialysis patients in a control group not receiving hemoperfusion, but receiving hemodialysis with dialyzers with a higher surface area than previously. Patients should be kept in the same dialysis mode, hemodialysis or hemodiafiltration, same time and surface, etc., as the start of the study for the whole study period. We want to assess whether patients on chronic dialysis care program will demonstrate positive results in the terms of decreasing the level of pre-dialysis urea, creatinine, PTH, phosphorus, and other uremic toxins, and change of subjective symptoms such as itching, bone pain, lack of appetite, sleeping disturbance, restless syndrome, and parameters of physical and mental condition. Present results to relevant health authority in Federation of Bosnia and Herzegovina to apply for potential extension of additional investment and fund allocation for procurement and supply of hemoperfusion devices in established hemodialysis center in Federation. I would like to emphasize Bosnia is from Republika Srpska and Federation, and we spoke now about implementation that in Federation of Bosnia and Herzegovina. Published results in scientific journal will be. We want to examine the possibilities of enhancing and expanding the range of services currently provided in the Federation of Bosnia and Herzegovina through the application HA130 hemoperfusion devices with aim to decrease parathyroid hormone, phosphorus, urea, creatinine, and consequently improve the quality of life of the chronic dialysis patient. Also, in parallel, the study will imply mechanisms to check and control influencing factors. That will make that laboratory test that will make total protein, urea, creatinine, PTH, phosphorus, that is uremic toxin, all what we want to make, beta-2 microglobulin, and also FGF23. That would be one short pilot study with 10 patients be followed a month without control group and no clinical assessment to assess the kinetics of uremic toxin during and after one hemoperfusion session. Prospective longitudinal cohort study over the 6 month period for 10 maintenance hemodialysis patients on hemodialysis and hemodiafiltration, beneficiaries of hemoperfusion to determine how application of hemoperfusion devices affects the concentration of urea, creatinine, parathyroid hormone, phosphorus, and other uremic toxin, such as precressyl sulfate, indoxyl sulfate, beta-2 microglobulin, and latest one large middle molecule retinol binding protein or short chain immunoglobulins FGF23. Measurements to be performed at the first dialysis session of the week, and subjective perception of patient with focus on quality of life will be assessed in parallel. Study protocol will be created by sponsors of the study, implementing institution. Study location is University Clinical Center Sarajevo, Clinic for Hemodialysis, time frame 6 months, and clear inclusion criteria for chronic dialysis patient, focusing on chronic dialysis patient with elevated parathyroid hormone and phosphorus. Basal patient characteristics be registered, and therapeutic regime with the HA130 hemoperfusion device to be applied during this study. Informed consent of patient, confirmation of adequacy of laboratory equipment, laboratory results form, summary laboratory results, summary compilation form of patient subjective perception, instruction of data, processing of data and interpretation, results evaluation, and report form. Thank you.
Okay. Thank you, Lima. I really believe that this is the right way to investigate better this new technique that is very promising. Several clinical study, little clinical study have done. We have listened at very interesting information, very interesting point of view, but we need really much more clinical study, controlled clinical study, just to give an idea to ourselves and our colleagues of the really improvement that we can achieve with this technique. First of all, I would like to say that no side effects have been described in a great quantity, apart of two clotting episodes that can be avoided. So the technical seems safe. We need to better investigate the clinical studies and the clinical patients that can be receiving this technique and improving. We have mentioned mainly calcium phosphorus disturbance, high PTH, refractory hypertension, and very interesting, someone have proposed also hyporesistance that can be a very interesting marker of chronic inflammatory state of our patient. So we have to join our force and try to produce much more clinical study, and we hope that Jaffron will help us to do this. I would like to thank all our speakers. Thank you very much for your presentations that have been very clear and very interesting. And also I would like to thank the participants that have been listening us by web, and of course Jaffron and Grace and for the technical assistance. So thank you very much to all, and I am now closing this webinar. Have a good day. Have a good day, everyone. Thank you very much.
Thank you.